This UCSD TV program is a presentation of University of California Television for educational and non-commercial use only.
Hi everybody, I'm Dr. David Granite, and welcome to Health Matters. Today our topic on the table will be that of menopause. Now I know a lot of people have many questions about this, and it's been an evolving field. We're going to welcome back one of the world's experts in this topic, Dr. Cynthia Stunkel. Welcome.
Hello, thank you.
Dr. Stunkel is a professor at UC San Diego School of Medicine and the immediate past president of the North American Menopause Society. So we are just thrilled to have you once again here. And before the show, we were talking about how the last time you were on to now, things have changed. There's been a growth in the field and information to share.
Well, I think one thing that we can say for sure when I talk with women or I talk to my colleagues about menopause is the only thing we can say for sure is what we know today, and that probably within a year from now the story might change a bit. So it's the kind of thing that you really have to stay on top of all the new information.
My first day at Yale Medical School, George Palade, who eventually came here to UC San Diego, said, "We are 100% sure that half of what we teach you will still be true in 2 years. We just don't know which half." And so I think that's true of medicine. We have to give our best information today. So I said the topic is menopause, and I think that we have to define some terms.
Okay.
And to do that, can we start with some basic reproductive information about the reproductive cycle, what goes on, and then where we get to menopause before we get to treatment. So let's start there.
Well, I think most women are very comfortable that they have a monthly cycle, and I think most women understand that there's a symphony of hormones that are changing during that time. We know that we have two primary hormones that kind of regulate our bodies, and both of which are really designed to prepare our bodies for pregnancy. I mean, for evolution of the species. That's what it's about, is propagation. So estrogen is the first hormone that we know increases till about the middle of the cycle when an egg is released. And then in the second half of the cycle, which is called the luteal phase, there's an increase both of estrogen and then a second hormone called progesterone. The point of the progesterone means progestare, towards gestation or towards pregnancy. So it actually prepares the lining of the uterus to accept that fertilized egg should that occur in that cycle. Then if pregnancy doesn't occur, which obviously is the situation the vast majority of the time, then women will have a decline of both hormones, and then they'll have their menstrual bleed. And that pretty much concludes the series of events over the course of a month.
What tells these hormones to change throughout the cycle?
Well, everything happens above the ears, and that's why I think in a woman particularly, her mind, her frame of mind, her state of mind is very important, because we know that emotions, stress, certain other situations can affect our reproduction. The hypothalamus is the name of the highest center in the brain that gives signals to a gland called the pituitary gland. And then it talks to the ovaries and says, develop eggs during this part of the month, release eggs during that part of the month, and gets feedback from the hormones from the ovaries as well to kind of keep this whole beautiful cycle working.
Now that cycle does not go on forever.
No, it does not.
What happens?
Thank goodness.
Yeah.
It does not go on forever because, and the most simplistic way that we understand it, is that simply little girls are born, actually it's 7 months of pregnancy, when they're still in their mother's womb, little girls have the total count of eggs that they will ever have in their life. And starting even before birth, there's a gradual decline or drop-off, or the formal term we use is atresia of these eggs or follicles. And what happens is with time, this just kind of picks up in speed until a woman's in her late 30s, 40s, for some women into her early 50s. This process moves along until there are literally only about 1,000 follicles or eggs left in the ovary, and that's when women start missing cycles, and then eventually there are no more eggs, and that's when the whole system stops. And woman is menopausal then.
So that's why or sort of the whole process of where we go to. But what happens in the body as those eggs diminish that changes?
Oh, many things.
And there's a whole host of words that you look, from reproductive stages, premenopausal, perimenopausal. I want you to take us through what those stages, what they mean, and what's going on in someone's body that they may not even realize are the beginnings of these changes.
Right. Well, during the reproductive years, we would call that would all be premenopausal. So a premenopausal woman is someone who's having her cycles and having babies and worrying about contraception and all the usual things that we think about in our 20s, 30s, 40s, and maybe into 50s. The perimenopause is a term that's also used interchangeably with menopause transition. And this transition is still a little bit undefined exactly. When does this begin? One of the most frequent and one of the most common signs that women might notice is that their menstrual cycles start to change. So some women might notice that they're having periods more frequently than they used to, that instead of every 28 days, now it's 26, 25, 21. That might be a sign. Other women might notice that their cycles are becoming much heavier and kind of out of control, and sometimes very almost debilitating bleeding that can cause anemia or just interfere with their day-to-day existence, so changes in bleeding. Other women might notice that they never really noticed mood swings before, but all of a sudden they can really tell that something is different.
But there's so many things that go on in one's life.
True.
That's the same age if you've had kids, they may be teenagers now, right?
Yes.
So life is changing, and so you may be frustrated. Do people always recognize that those changes are taking place, or do they attribute them to something else?
Well, that's a really good point. And many times it takes a while of going, wait a minute, is there a pattern here for people to recognize it? And so I do think they could blame it on other things. Some women will come in and just say, something's different with me. I'm just have a shorter fuse than I used to have. I'm a little more irritated. And so the best thing that I advise women to do is just to keep a calendar. It's not high-tech. I guess they could make it high-tech if they wanted to, but
there's an app for that
just
somewhere.
keep a calendar so you know where you're at in your cycle, and I think that helps women notice if something's changed or if there's a new pattern.
And I'm getting the sense in talking to you that some women go to their doctor to talk about this, although I'm not sure if they know which doctor to go to. You can help us with that. And that some need the physician to ask, how are things going, and raise the issue. Do most people bring it up to their doctor, or does the doctor have to bring it to them? How does that work?
Well, in my experience, the best forum for this kind of discussions would be my book club. And I really think a lot of women are talking to each other, and they're saying, have you noticed this? Is this going on with you? Or you're a little bit older than I am, you're a little bit younger. I always encourage women to bring this up with their doctors. I think many physicians and other clinicians are attuned to this and would say, ooh, you're getting to be a woman of this age, have you noticed anything new? Are you having cycle changes or other changes? But, I always encourage women, if you notice something's not quite right, then bring it up yourself.
That's a great piece of advice. So we see these changes coming. I want you to give me both sides of this coin. Is there anything someone can do to slow the onset of menopause in terms of their own health? And are there things that people do that make it more likely to come on faster? So both sides of that.
Right. We think that a lot of the timing of how those eggs are falling off might be genetic. And so, knowing when your mother experienced menopause might be a clue. We don't really think that we have much we can do in the way of moving it forward or holding it back. Some women will ask, well, I took the pill for 20 years. Did that kind of keep things quiet so my eggs now will have 20 more years to work? No. This process continues on, even women taking contraceptives. We know that women who smoke, for example, can speed things along, that for some reason smokers have a couple years earlier menopause. Sometimes women with type 1 diabetes might have a bit of an earlier menopause. Again, we're not sure exactly why, what's going on. Some women with certain, and some of these are very unusual conditions that have certain genetic abnormalities of the X chromosome, so the things that give us our femaleness, might go through normal puberty, have normal cycles, even have babies, but they might just say, you know, all the women in my family go through menopause in their early 30s. And so when we do a test called a karyotype and evaluate those chromosomes, we can sort that out. As far as, you know, putting on the brakes, you know, wait a minute, I just finished, you know, my medical residency and I want to postpone this a few more years. I don't think we have a way to do that.
Now, I've talked about this on the show before. My wife and I did in vitro fertilization. We're injecting hormones, and we're stimulating lots of follicles to each cycle to try and increase the odds of having a baby. Does that bring on menopause earlier?
Right. It's a great question. I don't know the answer to that.
Okay.
I don't
Fair
think
enough.
it's understood. Yeah.
My guess is that eventually we'll have an answer to that kind of question.
Well, as procedures like IVF and other reproductive technologies become more broadly available, I think we'll be learning more about that. But at this time, I don't know. It makes sense what you're saying if you're revving up and using more eggs, but I don't know.
Yeah, what makes sense isn't always true, so that's why I asked.
Exactly,
Yes.
yeah.
So let's get specific. You talked about some mood changes that can occur during the menopausal time period, because I'm not sure exactly the right terms, so if I mess it up, you
No, you're
correct
doing
me.
fine.
What are the other signs and symptoms that are known to be associated with this versus the ones that are kind of people think are associated with it? I'm going to guess somewhere in there we're going to get to hot flashes.
Right.
But there are others that are kind of unclear. So
certainly hot flashes can come on, and as you questioned earlier, this is something that, you know, there's no trial run for having a hot flash. Women don't know what's happening to them. I've seen women come in and saying, I think I'm having anxiety attacks because I wake up at night and I feel hot and then I get cold and my heart's racing a little bit. And then the more you talk, you go, you know, I think these sound like hot flashes. But other things can confuse women about hot flashes, things like thyroid disorders, certainly too much thyroid hormone. And there are a couple other medical zebras that can present with symptoms that can seem like hot flashes.
So no hand waving when someone says it says hot flashes and you go, oh, that's just menopause. The doctor has to pause for a second and make sure that those symptoms aren't associated with some other problem, even though it's not as common.
I think it's important to listen, and the time when I really think the red flag goes up is if a woman takes steps to help her hot flashes with a trial, for example, of hormone therapy, and says it's not touching it. That's the red light for me that always says time to look into this. But the other symptom that women have that they don't always recognize or think about is vaginal dryness, and this can come up before menopause occurs, and they might be thinking, you know, oh, I'm married too long, I'm just not in the mood, not enough time for foreplay or getting receptive, and in fact, it might be their hormones that are contributing to this, and, you know, when they realize that, it can make things a lot better.
Is the vaginal dryness the same as the sort of decreased libido that you can read about if you Google all this, or are they connected, or are they sort of separate issues?
Well, I think they're connected in that if a woman is uncomfortable having sex, she's going to say, I'm really not interested in going there. But there are some thoughts that women might also have changes in their interest, in their desire, in their wanting to be receptive in sex that might imply that there could be some libido changes as well. But I would step back for 1 second and say you brought up, you know, what's happening at home and the teenagers. Midlife is an incredible sort of crucible for women between work and children and parents and all their obligations, such that I'm not sure if libido really changes or it's just like, you know, I need a vacation from my life and all of a sudden I'm interested in sex again. So I think that women have to cut themselves some slack when they are going through this and not just blaming things on, it must be my hormones.
Got it. We're going to talk now a little bit about the treatment options, but I'm going to jump ahead just for a second because we talked about symptoms and say some of those symptoms actually can be prognostically good if you get some of these early enough, right? I mean, some of these things, we can turn them a negative into a positive by saying, hey, if you got hot flashes and you're young, for example, maybe that's good for your cardiovascular system.
Well,
let's make it a positive.
Yeah, there's been some information that's come out of, in particular, one long-term study that's followed women through the menopause transition. It's called SWAN, the study of women across the nation.
Got it.
Looks at different ethnic groups in different cities. It's a well-done study. And some of their information has been kind of concern because they're suggesting that perhaps women who have hot flashes might have an increase in some measures that would be associated with an increase in heart risk. It turns out a lot of those women are probably also heavier than they should be or obese, and that maybe that's more of the question. But what's come out just new in the last couple months, and you might have seen the pictures in Time magazine, suggesting that, and this is from the Women's Health Initiative observational study, so a huge follow-up of 60,000 women followed for 10 years, and suggesting that women who have hot flashes at the time of menopause are really normal, and that maybe a hot flash is a marker of a healthy vascular system. And in fact, when followed up for 10 or 15 years, these women had fewer heart attacks, fewer other cardiovascular events, and a lower mortality. So I think that's a positive mark for hot flashes are okay.
All right, so give me 30 seconds. What's a hot flash medically? What happens?
I will tell you what we know medically, because our knowledge is not as clear as we would like it to be. What we think is happening is that the body, at the time of menopause, kind of has a narrowing of what we call the thermoregulatory zone, meaning, you know, what temperatures I'm going to be comfortable in. And so higher than that, I'm going to get warm, and that may induce a hot flash. Colder than that, I'm going to be more cold. And so that whether this is due to hormonal changes or aging isn't quite clear. But what happens is that women will suddenly get a signal that we think has to do with the brain and says, you're too hot. It's hot in here. So the body goes through this whole response to cool off. So women will vasodilate, meaning that their vessels open up. Some women will actually get a flush that if they're looking in the mirror, they may look red. They will break into a sweat that's often around their neck, their chest, sometimes their back. And for some women, yeah, they'll be fanning, take off the jacket, you know, set the thermostat to 66, which can make problems in the bedroom or the boardroom, both. But, and then with a few minutes' time, this passes. And in fact, the body's done such a good job of cooling the woman off that she actually probably feels cold. And we'll pull the covers back up on the bed or put the jacket back on or, you know, in some way. So we don't know exactly what this is about. I like to say that we have sent men to the moon and we have cracked the genetic code, but we do not really understand a woman's hot flash.
That's unbelievable. So treatment-wise, because that's really what everybody wants to hear right now, we'll start with grandma treatments, the non-medical, non-drug-related lifestyle sort of stuff.
And these are good, and they can be important. So we've already kind of given some allusions to women learn to dress in layers. Throw away the turtlenecks. Can't stand a wool sweater anymore. You know, be prudent about what you wear. So that's number one. Number two, there are some things like yoga or paced breathing that can just kind of come down and help women to center themselves. This helps some women. We learned that women who lose weight can have a reduction in their hot flashes, that obese women actually seem to suffer more, and that with the loss of a few pounds, that can be an improvement.
Smoking?
Smoking doesn't really seem to affect it, but some women will learn what their triggers are. So hot coffee, that first sip of a glass of wine, spicy foods, heaven forbid chocolate, but...
Over-the-counter stuff? Soy, clover, I'm looking what I found when I looked this up, vitamin E. Does that work?
Well, the placebo effect for almost anything that a woman tries is about 40 to 50%. So that says that women may find relief. When these are carefully examined in clinical trials, it's inconsistent at best. So some women do find them helpful. If a woman wants to eat soy food and drink soy milk, I don't really see a downside to that if it makes her feel better.
Acupuncture?
Acupuncture, magnet therapy. I mean, if you've got the time and the...
no good studies that prove these work.
They aren't shown to be particularly effective. But again, a placebo effect is so high, and if a woman finds relief, and she's going to a decent place, and I'm not going to argue with that.
Doctor stuff, non-hormone medicine.
Yeah, these have been carefully explored initially in women with breast cancer. And we all all know that women who start breast cancer chemotherapy can often be plunged into menopause. And so these women can have a particularly rough time with symptoms. So there have been some very good clinical trials looking at some of the same drugs that are used for depression, some of the SSRIs, the
SNRIs.
Yes, thank you. I don't know why I always get tripped up on that, but some of these very commonly used antidepressants can help with hot flashes. There's another category of drugs called gabapentin, which is used for seizure treatment. It can help with hot flashes. And then finally, a blood pressure drug called clonidine, which has been used for a long time, but in smaller doses can also help some women with their hot flashes. So these are options for women who can't or choose not to use hormone therapy.
So 20 minutes in, and we finally get to hormone therapy. But you have to go through this to get there, right? I mean, otherwise it doesn't make any sense. Hormone therapy that has a long history, a controversial history, but now a pretty well-studied history. So we have a lot more information than we used to have. And as far as I can tell, there's a difference between whether you have a uterus or whether you don't have a uterus and what you do.
A huge difference. And so women who don't have a uterus, who are having symptoms, and this can affect women who have their uterus removed when they're younger than the average age of 50 or so for menopause. So these young women really need to look seriously at hormone therapy, can just take estrogen alone. And from the Women's Health Initiative, we are learning that the risks with estrogen alone are actually much less than the risks with combined therapy. Combined therapy because if you have a uterus, we know that estrogen alone can stimulate the lining of the uterus and increase the chance of cancer of the uterus. So that's why we have since the 70s or 80s used a second hormone. The challenge now, I think, is we'd like to back off a little bit and find some more creative ways to protect the lining of the uterus without necessarily exposing women systemically to the second hormone, the progestogen.
Yeah, I mean, the idea of we're not treating the disease of menopause, we're treating the symptoms of menopause,
We're treating the symptoms of menopause.
And you don't want to increase someone's risk for some serious diseases, but we don't want to leave them frustrated and having difficulty living. So there's a balance that we have to do. Who are the people who are right for hormone treatment that you would say this is a group that it really makes sense for?
In general, number one, women need to be symptomatic. We're not prescribing hormones for prevention for anybody anymore. So women with symptoms. Women who are close in time to menopause, which usually says they're going to be in their 50s or maybe even a little younger, or within 10 years of menopause, depending when they have it, because we know that the risks for heart attack, stroke, blood clots all increase in the older women. So that's important.
Increase starting in older women or women who are older and still using hormones?
Women who start when they're older.
Okay.
So in the Women's Health Initiative, some of those women were 10 or 15 or 20 years beyond their menopause, had never used hormones. But remember, back in those days, we thought we were preventing things, and we started in older women. So women who start older might get into trouble. Certainly a woman who is free of things like breast and uterine cancer, women who are in good cardiovascular health are good candidates, women who know that they're not pregnant. We always think when periods start getting irregular, that's a good thing to check. They don't call them change-of-life babies for nothing. And women who have not had blood clots. Those are our main kind of checklist for, are you a safe candidate?
Is there sort of an algorithm where you kind of go down and say, you know, yes, yes, no, yes, where it helps you make a decision?
Well, I like to really have women think about their cardiovascular health because we know that heart disease and stroke are the main cause of morbidity and mortality, sickness and death in women. And so I think it's worth going through what are their stroke risk factors, what are their risk factors for heart disease, and we have some very good online formulas to be able to do that. And then we need to think about what is their risk for breast cancer. And it's turning out that one of the newer risk factors that might be very easy to check on in most women is breast density on their mammogram. And that's something everybody's getting an annual mammogram, I hope, anyway. And so that may be a clue to help us know.
You start when you're in your 50s. If you're in the right candidate, you have symptoms. When do you stop?
Yeah, when do you stop? That would be the $64,000 question, is when to stop. We're currently recommending that women take hormone therapy because we're saying it's a drug with risk, so it is a therapy, for probably a few years. So maybe 2, 3, 4, 5. This is a little bit vague at the moment. But the concern, particularly with combined hormone therapy, is we don't want to be increasing the risk of breast cancer. And that's certainly the main concern. And so we are being cautious in that way and suggesting that women limit therapy to a short time. Now, some women might say, no, I don't want to stop. I feel good on this. I don't want to go back. And in that case, I think it's just as a careful conversation to review her other health care situation, review her concerns, and make sure she's having her mammogram. If possible, you try to lower the dose perhaps and see if she can still have relief and be feeling well, and reassess it on an annual kind of basis.
That was one thing that I was struck by, that the dosing of this isn't that you give a big slug, that I was getting the impression that you use the least that you have to use.
We are really trying. I think there's been a lot of controversy after the Women's Health Initiative, but it's helped us to know, and we're trying to lower the doses. Do we have proof that it's safer? Not in the same kind of clinical trial, but there's a number of what we call observational studies that suggest that women might have less stroke, less heart attack, and potentially less breast cancer with lower doses. So we're trying to do lower doses and, again, be very careful in how we select candidates for hormone therapy. I am a proponent of FDA-approved therapies, though. I am not a strong advocate for some of the compounded therapies. But this is partly where the personal preference comes in, and this also might be modulated somewhat based on her other health risks or concerns. She can take pills, she can wear a patch, she can apply a gel on her arms, she can apply a gel on her leg, she can use a vaginal ring that will deliver the hormones systemically. So it's kind of, you know, we can really work with women as far as what they're interested in.
I see commercials and infomercials and talk show people talking about bioidentical hormones, and what is that? How does
Well,
that
as an endocrinologist, bioidentical means that the hormone looks like the same one that a woman's ovaries make naturally. But that term has been somewhat twisted a little bit in our current climate, and bioidentical is often used now by women to mean compounded hormones that are formulated specifically, tailor-made just for them at a compounding pharmacy. Groups like the American Medical Association, the Endocrine Society, the American College of OBGYN, NAMS, our North American Menopause Society, are uncomfortable with the way women have embraced these because they are not tested in clinical trials. We don't know for sure that they work. I certainly don't have any evidence that they work better. We don't have any evidence that they're safer, and they don't come with labeling to let women see what the risks are, which we think for these compounded hormones are at least the same as with the FDA, if not perhaps greater.
And the dosages could be different because they are being formulated
When
different.
these have been measured, it's very hard to know that there are even consistency in the content of many of these preparations.
So I'm going to give you a chance to throw a tomato at me in the very short time we have left. Male menopause?
Yeah, you're just jealous.
I
Male menopause.
don't know, after listening to this, I'm not sure that I really want to go through menopause.
Well, this is what I don't understand, but certainly there is no comparable physiologic event in men that's associated with an abrupt and dramatic decline of their sex hormones as women experience. We do know, and I'm sorry to tell you, that in men, starting probably in their mid to late 30s, that there is a slow and gradual decline of testosterone. No, Picasso was 82 when he fathered his last child. But that there may be a decline in testosterone. And so if men feel a sense of fatigue, loss of stamina, certainly if they have problems with their sexuality, then they should be evaluated to see if for some reason they may have a low testosterone.
Oh, I thought you were going to beat me up more than that on this one.
No.
So medicine marches on, and can I get a commitment from you that as the knowledge base marches on, that we can get you back to talk about this again, because it's not going to go away. People are always going to want to know more.
Yes, thank you. I'd love to.
Thank you so much for joining
us
today. Well, you've been hearing a true expert really take us through this topic in just a beautiful way, Dr. Cynthia Stunkel, and I can't thank you enough for coming on. This is important for you to know about. Knowledge really is power, and the more you understand what symptoms you're going through, what's happening to your own body, the more you can help your doctor and partner in the care that you need. So please listen closely, raise these issues with your physician, and make sure that your questions get answered. I'm Dr. David Granite, and we'll see you again next time right here on Health Matters.